Thank you. So I'm going to paraphrase Brian Clough here. He was asked once what he thought about football in the Midlands. He said he thought it would be a good idea. So I would think research into post-thrombotic syndrome would be a good idea. I don't know how I'm going to have to stretch this out now until Mr. Black arrives, because I've only got 4 slides. So, this is what we think we know about post-thrombotic syndrome. We think it's common. So, it's said that up to 50% of people with a DVT will develop post-thrombotic syndrome. So if you do some back-of-the-packet calculations on that, given that we think it's about 1 in 1,000 people in the population get a DVT every year, it's about 30,000 cases a year. So it's not an insignificant number, okay? We think it's expensive, and whilst it's very difficult to kind of get any exact figures, I've seen a figure of £128 million per year spent on treating venous leg ulcers, the majority of which we think are due to either overt venous thrombosis or indeed venous thrombosis that wasn't diagnosed. And we think it's debilitating. And I must say, I was very struck by the patient stories from last year's World Thrombosis Day about quite how debilitating post-thrombotic syndrome can be. And I was very struck by Carl's story about the whole kind of patient story and the patient pathway. So that's what we think we know. This is what we actually know. And do you know why we know the square root of bugger all about this? Because we don't even diagnose it. There is no diagnostic code for post-thrombotic syndrome. There is not a blood test that you can do. So if I want to diagnose somebody with diabetes, I can do a blood test, and if their sugar's high, they've probably got diabetes. If somebody has acute chest pain, we can do an ECG and see the signs, and that tells us that the patient's had a heart attack. There are about 6 different diagnostic criteria out there, diagnostic tools out there, ranging from invasive tests to asking the patient. There was, in about 2010, the International Society for Thrombosis and Hemostasis, which you've heard of already today and which sponsors the whole World Thrombosis Day event. They said that we should be using a thing called the Veloster Score. Now, the Veloster Score is a combination of patient-reported symptoms and objective signs. But we don't use it. No clinician I know in the UK uses it. It's only really been used in research. So if I want to know how many patients in my practice have got asthma, or what percentage of patients in my practice have got asthma, it's dead easy. I do a computer search on what's called a read code, and I can find out of my 10,000 patients, 1,000 of them have got a diagnosis of asthma. It's got a prevalence of 10%. We do not even diagnose it in the UK. Even when you get a venous ulcer, it's unlikely to be classed as post-thrombotic syndrome. So that's the start. If you don't even know what you're dealing with, how can you then say it's costly? How can you then say it's debilitating? So I think what we need to know is how common it actually is in the UK. And I can tell you there's only one person in the world who's done research into this, and that's a lady called Susan Kahn from Canada. There's been no research in the UK on this whatsoever. So we don't know how common it is, and we don't know who gets it. Given that, how can we even attempt to describe how expensive it is? And how can we, going back to Simon's stuff from this morning, has anybody actually gone round and asked patients what it's like to live with post-thrombotic syndrome? The answer to that is no. So I'm actually, at the moment, in fact, it's got to be in by next Tuesday, applying for some money to the NIHR, and Beverly's very kindly been involved, and I think I need to involve Simon. I'm sorry I didn't involve you in the first place, but we will do if we get the money. So this is an NIHR program grant, which is going to start, and it's a start, it's not going to answer, it's a start to try and answer some of these questions. So our first work package is we're going to try and pick up 1,000 patients with the first diagnosed DVT and follow them for 2 years and basically see what the incidence of post-thrombotic syndrome is in a UK population with a first diagnosed DVT. The second bit of that work package is also to try and look at who is at high risk and who is at low risk. We're trying to develop some kind of prognostic model so we can perhaps divert resources towards those who are most at risk of getting it. Because at the moment, we have no clue. We do know that if you have a recurrent DVT, you are much more likely to get it. But there's things like, it's likely to be, things like BMI, how well your anticoagulation was controlled, how big or the site of your clot in the first place. There's some suggestion that residual thrombosis may or may not be there. So we're trying to look at those things as well to see if we can develop a prognostic model to see who is likely or not likely to develop post-thrombotic syndrome. The actual key bit, I guess, and what drove this was a randomized controlled trial of compression stockings. So again, sorry to preach to the converted, but we always thought that the use of elasticated compression stockings was the best thing we could do in terms of preventing post-thrombotic syndrome. And Susan Kahn, who I mentioned before, brought out a study a couple of years ago now called the SOC study, which suggests that they don't do anything of the kind. But there are issues about how many patients who were supposed to be taking the stockings actually wore them for any significant length of time. So we thought it was actually justified just to repeat the SOC study, but we thought that whilst we're doing that, we ought to add some value. So we're also looking at whether exercise does or does not prevent or help to prevent post-thrombotic syndrome. On the back of that randomized controlled trial, we will be doing a health economic analysis, which is essentially saying, is the cost of providing stockings and exercise worth it? But also beyond that, we will be developing a health economic model which will be available for anybody to use in the future for any future interventions, be they drugs, be they behavioural, be they whatever. And close to Simon's heart, we're going to ask patients what it's like to live with post-thrombotic syndrome, because nobody's bothered to do that yet. And I was really struck at last year's World Thrombosis Day by the patient stories about what it was like to live with this. And if it really is as common and as expensive as we think it is, then it's probably about time we ask patients what it's like to live with it. So my plea to you is, if you get to review this grant, please say it's a good idea. Thank you very much.
Has anyone got any questions for David? Here we go.
I was just wondering could they be re-scanned, the patients re-scanned, so at the end of if they're on 3 months treatment?
Generally not, no.
No, I know generally they're not now.
We won't be, no. So the work package one, we're literally just going to follow them up and see what happens. If they happen to get rescanned, we will have that information, but that's going to be few and far between, and we certainly won't be doing it as part of the RCT.
In America, they usually seem to rescan, so is there not data available in the United States? With the litigation-conscious society, whenever I read on the internet people's experiences of having DVTs, they commonly mention that they have a scan and diagnosis.
It would appear and it is limited data, that it's not useful. Hence, it's not become part of routine practice. But it is limited data. Yeah.
I just want to say I can vouch for that because I grew up in America. And
Really?
Yeah, my first 2 DVTs. As far as following up on post-thrombotic syndrome and all that, there's
No, they're not. And as I say, there's only Susan Khan, who's from Montreal. She's the only person who's really done any substantial research in this area, who's thankfully a co-applicant on our grant as well.